Presentation, I'm going to go over Meniere's disease. Meniere's disease occurs, I'm going to go over the pathology, and I'm not going to go that deep, but I'm just going to give you a basic idea. It's an inner ear problem. So what happens is there's swelling of the cochlear, which helps us hear, and the labyrinth, which helps us with balance and proprioception. Okay, so the result is damage to both hearing and vestibular structures. Okay, so it's unilateral, it happens on one side, so the patient is going to have intermittent vertigo. That's one of the symptoms of it. Nystagmus. Okay, that's the involuntary eye movements. And they'll have unilateral sensorineural hearing loss. And the hearing loss is gradual and it fluctuates. Okay, so the Weber test is done. If you do a Weber test, they're gonna hear in the normal ear. Okay, so remember the Weber's test is when you put the tuning fork on the forehead like a weather vane, and you click the tuning fork. I'm going to bring one to class so you can see what a tuning fork is, and you put it on the forehead, and the patient is going to tell you that they hear better in their normal ear. That is an indication of sensorineural hearing loss. And it's called lateralization, like it's a Weber test is a test to determine lateralization, which means all that means lateralization means which side does the patient hear the tuning fork better. That's all you need to know about that, okay? Complications of Meniere's disease. I talked about vertigo. It's episodic. It comes and it goes. They have oral fullness, which means the affected ear is going to feel like there's fluid in it because there is. And then I talked about the sensorineural hearing loss and tinnitus. So with tinnitus, that's like ringing or clanging in the ear, and that comes and goes as well. And that's because it's a neural hearing loss, not a conductive hearing loss, okay? And I'm going to go over the difference between conductive and sensorineural in class. They're going to be at risk for falls if they have vertigo. And so during vertigo episodes, of course, you're going to want to put them in bed, tell them not to get out of bed with help, turn the lights down low because they feel like dizzy, right? Keep their head in one spot. Like you might put two pillows behind next to their ears to keep their head nice and straight. All right. If they have hearing loss, one of the things you're going to have to make sure they have at home before they go home is use flashing lights instead of warning sounds for alarms and doorbells. So you have to make sure their home is equipped with the flashing lights to alarm them if there's an emergency going on or somebody's at the door. Risk factors include females, usually ages 40 to 60. I just put this in here because if somebody does have Meniere's disease or any other disease that may cause sensorineural hearing loss, they need to really watch these medications because these medications could in and of itself cause sensorineural hearing loss. But for somebody that already has it, it could add injury to insult. So you would have to, like, for example, do your peaks and troughs on your aminoglycosides. Those are your myosin medications. NSAIDs and aspirins cause ototoxicity and tinnitus. Loop diuretics, furosemide, ethacrynic acid, and platinum-containing medications like the chemotherapy agent cisplatin. Okay, so those medications are ototoxic. You're going to be tested throughout nursing school about those medications being ototoxic. Okay. And when you're giving medications in clinical, your instructor is going to ask you about that. So you're going to have to know that. Okay, the diagnosis. The Weber test I mentioned before. So the patient is going to hear lateralization to the normal ear, so the unaffected ear. The Rhine test, the air conduction is going to be greater than the bone conduction, which is normal finding in the normal Rhine test, but there's going to be a decreased length of time for that to happen. They can also get something called an ENG. You don't really need to study this, I don't think, but I think you could figure out if you got this on NCLEX that this is to test for nystagmus. That's a test for nystagmus. You can also, if somebody has nystagmus, you might trigger it by doing The assessment of the extraocular movements, that's where you move the eyes in 6 different planes. That could trigger nystagmus. Okay, so before that test, they're going to have to restrict caffeine, antihistamines, alcohol, and sedatives for 7 days. I wouldn't worry about that so much, okay? This is, I think, what you'll be tested on more. They need a low sodium diet, no MSG. They need to limit caffeine and alcohol. And this is all the time, not just when they're having an attack. They're going to be prescribed diuretics, but you have to use caution if it's a loop diuretic because it's ototoxic and you're giving it to somebody that's already probably experiencing some type of hearing loss. Antiemetic medications while somebody's having an attack, and antihistamines. While they're having the attack, they should not move their head suddenly and they should be in a dark room. I think I mentioned that already.